The classical medical model of assessment and treatment is a sequential process involving a full history, thorough examination, investigations, diagnosis, and then treatment. In this model, treatment is only initiated when the diagnosis is firmly established. Unfortunately, the model is only appropriate when there is sufficient time, which is almost never the case with seriously ill patients. The amount of time available for assessment is a key early decision. What are the systems that you would look at first to assess how much time you have and whether the patient requires immediate resuscitation? Think about it for a minute, then we'll continue. Hopefully you chose airway, breathing, and circulation because it's problems in these areas that have the potential to kill patients very rapidly. But what are the key points to bear in mind when assessing the airway, breathing, and circulation? For the airway, the key points are stridor may be absent in airway obstruction, particularly in severe cases. A normal oxygen saturation does not exclude a compromised airway. Hypercarbia and decreased consciousness indicate that compensatory mechanisms are exhausted. Bradycardia in a patient with airway obstruction suggests impending cardiorespiratory arrest. And, as in all critically ill patients, assess the sympathetic response as the magnitude of the response gives a guide to severity of illness. For breathing, the key points are marked tachypnea is a good marker of a severely ill patient. Pulse oximetry is very useful, but significant desaturation is a late feature of inadequate ventilation. Tachypnea in the absence of respiratory failure may be due to metabolic acidosis or sepsis. A low respiratory rate may indicate impending respiratory arrest, and again, assess the sympathetic response. You should worry if the patient has any of these features. For the circulation, remember that hypotension is a late feature of shock, so it is important to assess tissue perfusion, which you can do by looking at the features listed here. If the patient does have evidence of shock, i.e. inadequate tissue perfusion, try to determine the type of shock by examining the heart rate, jugular venous pressure, and the temperature of the peripheries. Determining what constitutes hypotension can sometimes be difficult as it depends on the usual blood pressure for each patient. But treat all non-pregnant, non-anesthetized adults with systolic blood pressure of less than 90 millimeters of mercury as seriously ill until proven otherwise. A few will have no other signs of shock, but still need to be treated with great caution. As well as formally checking the airway, breathing, and circulation, get in the habit of assessing the appearance of the patient, as this may give you an immediate indication of the condition. The patient on the left is sweating, may not be conscious, is a horrible color, and has no condensation in his mask, suggesting that his airway may not be patent. In contrast, the patient on the right looks much better, is alert, and has condensation in his mask, indicating that moist gas is coming out of his mouth and nose, and that his airway must be patent. So, Let's assume you have decided you do not have much time before you need to start resuscitating the patient. How would you go about assessing her or him? The key concepts here are to do things in parallel, not in sequence. For example, you can feel the temperature of the peripheries at the same time as you take a history, and to only look for the information that you need to take the next step. Ultimately, you want to take a full history and carry out a complete examination. But this process is broken down into multiple steps. So initially, you just take enough history and carry out a brief examination to determine the immediate life-threatening problem and the probable cause of that problem. Resuscitation should then be started based on that probable cause. There's often insufficient time to be certain of the cause prior to starting resuscitation. While you are resuscitating the patient, take further history and carry out a more extensive examination to determine the underlying problem, probable underlying diagnosis, and to assess the response to resuscitation. This may allow you to provide definitive treatment while continuing resuscitation, and the response to treatment may tell you whether your initial assessment was correct. Further history, examination, and now some investigations should be carried out while treatment is ongoing. The aim is to reassess your diagnosis and to continue to assess the response to treatment and to revise treatment accordingly. You keep going around this loop until you are sure you have the right diagnosis, have given the right treatment, and that the patient is responding appropriately. By the end of the process, you should have taken a full history and carried out a thorough examination. It's just that the history and examination is broken up into pieces rather than being done in one go at the beginning. Similarly, the assessment of response to treatment and then adjustment of the treatment is not different from the process that has gone through in less acute branches of medicine. It's just that reassessment is carried out every few minutes, not every few hours or days or months. In fact, you should not leave your patient until he or she is stable. And to re-emphasize the point, do things in parallel as time is short. Seriously ill patients are often unable to give a history, so relatives and staff should be interviewed as well. Notes and charts should be read carefully, as often clues are present in the notes, but their significance was not understood by the person handing over to you. Ultimately, a comprehensive history should be obtained, but initially, history taking should concentrate on the immediate problem and on physiological reserve, especially cardiopulmonary reserve. This can be estimated from exercise tolerance and by asking about previous major illnesses. Remember, when you ask about exercise tolerance, it is not enough just to ask how far a patient can walk without stopping. You also want to know how fast and why she or he stops. It is also very important to know what treatment is being given, both treatment of the underlying disease and supportive treatment. This point is often missed or its significance not understood. These two houses are identical, except the house on the left requires no support and the house on the right is only standing because of the support. But who thinks the two houses are in the same condition and who would buy the one on the right? Clearly, knowing whether a house needs support to remain standing is a key factor in determining its structural soundness. In a similar way, knowing what treatment the patient is already receiving is important. On this chart, the red bars show the blood pressure, the dotted line shows the heart rate, and the solid line the CVP. While the patient is obviously quite sick, he is obviously less sick than the patient who is requiring frequent transfusion to maintain the same values. At a later stage, take a comprehensive history. As with history taking, a full examination should ultimately be performed. The initial focus is to rapidly determine how the patient should be resuscitated and the severity of the pathophysiological insult. The initial examination should therefore be a limited examination which should be carried out while simultaneously taking a history. Several elements of the examination can and should be carried out simultaneously. For example, when assessing a shock patient, it's possible to feel the temperature of the peripheries, feel the pulse, examine the JVP, and take a brief history simultaneously. When assessing the severity of the pathophysiological insult, it is important to remember that there are homeostatic mechanisms which are designed to ensure that certain key physiological parameters are kept as stable as possible. Thus, a fall in blood pressure results in vasoconstriction and tachycardia in an attempt to maintain a constant blood pressure. It is only when these compensatory responses are overwhelmed or malfunctioning that the blood pressure falls. It is therefore just as important to assess the magnitude of the compensatory response. Failure of compensation indicates very severe disease. Certain groups of patients are difficult to assess. These include the immunosuppressed and elderly, their inflammatory response is blunted, young adults, decompensation occurs very late, and trauma patients who have a high potential for multiple injuries. Appropriate investigations will depend on the clinical presentation, but tests that are often helpful in the critically ill include the ones listed here. Okay, before our final summary, I would like you to write down 3 things that you learned from this lecture that you think are important messages, perhaps things you would tell a colleague who hasn't heard the lecture. I'll give you a minute. In summary, beware of patients who demonstrate any of the listed features, particularly if they are acute in onset or severe. Patients with a greater number of these features are likely to be more sick